Good morning, good afternoon, good evening to you all. Welcome to today's session where we're going to reflect on some perspectives on recovery. We really appreciate that you've chosen to spend this hour with us and we hope you'll find it worthwhile. I'm Goodman Sbergo. I'm Scientific Advisor at ISSUP, the International Society of Substance Use Professionals. As you know, ISSUP is a membership organization for the global substance use workforce with over 42,000 members worldwide and growing. We are an international network that unites, connects, and shares knowledge across the substance use prevention, harm reduction, treatment, and recovery workforce. And our global mission is to make sure that the work of members is as impactful, accessible, and effective as possible. We do this by making it easier to discover and share evidence-based knowledge, best practice, training, and networking opportunities. So please remember that you can visit our website, issup.net, to find information on how to sign up for free membership and how to access a wealth of resources and publications. You can also watch recordings of webinars and see what's coming, so see what the listings would look like. So thank you to the ISSUP staff for providing technical support for this meeting. So before we get started, I just want to go over a couple of items to let you know how you can participate in today's event. You have the opportunity to submit text questions presenters by typing your questions into the question pane of the webinar interface on your screen. So you can send these questions at any time during the presentation, sooner than later, so we can start to collate them and pose them to our presenters if possible. So we'll collect these and address them during the Q&A session at the end of the presentations. A recording of this session will then be made available to you to watch on demand after the event. So you hope you'll stay with us for what promises to be an engaging session. So today's webinar is going to consider some perspectives on recovery and a shared platform between the Global Recovery Network and our ISSUP chapters from Botswana and India. And Matu of the Global Recovery Network is an advocate with national TOT certification as a recovery coach and is herself now 18 years in recovery. She's the vice chair of the Nakada board in Kenya and is the author of Sober Again, which has influenced a great many lives, and I'm sure will continue to do so. Ms. Matu will lead the presentation on evidence-based practices in recovery, which will present evidence-based practices that enhance recovery outcomes, focusing on strategic frameworks that can be applied across diverse cultural contexts, improve the quality of these treatment services, placing emphasis on building individual recovery capital, fostering family and support systems, and engaging community through supportive policies and laws. So essential. Dr. Samba Nyirenda from ISSUP Botswana is a general practitioner and a certified mindfulness teacher in Francistown, Botswana. Samba, I'm a huge fan of mindfulness, so we share something in common. Her work emphasizes lifestyle medicine, and she's certified in various therapeutic practices, including trauma-sensitive mindfulness and brief action planning. Her background includes contributions to tuberculosis and HIV research with CDC Botswana and co-founding the Botswana Alcohol AIDS Project. She also serves as the secretary of the Francistown Women's Institute. Dr. Nyirenda is going to lead a presentation highlighting the lived experiences of women in recovery in Botswana. So she's going to share stories of recovery capital that has carried these folks in the recovery journey and highlight some of the challenges that women in Botswana and Africa face in recovery, shedding light on the challenges and triumphs of these folks. Finally, Dr. Nimesh Desai represents ISSUP India. He has 4 decades of experience in psychiatry and public health and specializes in mental health and substance use disorder treatment and prevention. He's formerly the director of the Institute for Human Behavior and Allied Sciences and has led substance use disorder programs in India and abroad, including a Fulbright Fellowship at Johns Hopkins University. Dr. Desai also advises on national policy for mental health and substance use disorders and values innovative practices to enhance ground-level impact. We share that in common, Nimesh. Dr. Desai's presentation is going to focus on direct field experience in India over the last 4 decades, and will also draw upon learning as observed internationally. The talk is going to discuss different levels of involvement of persons in recovery and the relevance of the lived experience in general in intervention planning and delivery. So after that very long intro, because we've got so many esteemed speakers today, Ms. Matu, a very warm welcome to you, and I hand over to you to get us started. Thank you.
Thank you very much. Thank you, viewers. Thank you, panelists, organizers. My name is Anne Mathu. I am a recovering alcoholic from Kenya. I'm also the vice chair of NACADA Board of Directors. I also work as a recovery coach at the Dove Mental Health and Rehabilitation Center. And today we are going to look at Global Recovery Network. What is Global Recovery Network? Actually, it's an alliance of people that support recovery from substance use disorders. I joined GRN, or Global Recovery Network, in 2022. In US, I'd gone for a conference on CADCA, and actually we launched Global Recovery Network this year in Greece on 26th of June. That was the International Day Against Alcohol and International Day on Drugs. So on the next slide, GRN, that is Global Recovery Network, is supported by a consortium of international organizations. It provides a platform for members to build and reinforce recovery capital through the pursuit of lifelong learning, forge and maintain connections to support each other and advance the understanding and practice of recovery throughout the world. Actually, when I joined GRN, actually it was a very gracious moment for me to be part of a larger group, because there's a lot of stigma in substance use disorders, and actually, especially for women. Here in Kenya, it has been quite a problem. And by going public, actually, I was the first person or the first lady to go public in Kenya about my addiction. And actually, I realized I was the only person in treatment. Among 32 men, I was the only female. So I realized there was a big problem. And then now when I got to learn about GRN, I joined it immediately. So on the next slide, GRN welcomes both people in recovery, who are in recovery, and also those people who also want to walk the journey with persons in recovery, and those also who want to be in recovery, because it's actually easy to stop drinking and drugging, but it's very difficult. It's quite difficult without any proper support to maintain the sobriety. Maintaining the sobriety is the most difficult thing. Getting sober is easy, but maintaining the sobriety is quite difficult. So we need people to talk to work with us. We need to work with other people as well. Those of us who are in recovery, we should not be ashamed of what we've been through. That is our past. We've started a new journey, and it's by supporting other people that we'll be able to maintain our own recovery, by giving hope and reaching out to those who are still suffering, those who are still trapped in that pit of substance use disorders. It gives us also that pride that you are able to help somebody else because someone stepped into your shoes, someone stepped into your dark pit and pulled you out. So the key objectives of GRN include to support members to engage in dynamic, ongoing processes of building and reinforcing recovery capital in its many personal, social, and cultural forms. We have different cultures across the world, so it's always good to customize the program according to the cultures that do not approve substance abuse, and those ones that support, we embrace those ones that support sobriety. So we have different cultures, and for example, in our culture now, in my tribe, we are not supposed to drink as ladies until your last born daughter got married. That is when you are supposed to actually start drinking. But then you see now all those people are not following what our great grandparents were following, and that's why we see now the rate at which people are using substances, and the initiation age is also alarming, because like research we did, we saw that in Kenya the earliest a person is doing drugs is 6-7 years. So that's quite alarming. Our other objective is to facilitate opportunities for members to forge and maintain connections in support of one another at the grassroots level. We need to reach out to people at the individual, individualizing this recovery, getting down to that person in the village, getting down to that person who is suffering and in the community, because addiction or substance use disorders is actually a shame-based disease. When you're active, and even when a person is in recovery. I remember the first time that I went public, one of my aunties called me and said, "For how long are you going to shame us? Now, when you are drinking, you ashamed us. Now you have stopped drinking, you're still going on TV to say how you drank." So, and I told them, okay, fine. I want to come out so that people can know there is recovery, there is life after addiction. And that is why we need to reach out to people at the grassroots level, in our villages, in our schools, in our hospitals, in our churches. And I always say this is a collective responsibility. It's a shared responsibility where everybody should come on board, so that we can participate in lifelong process of learning about recovery. And the moment we learn, the moment we are able to embrace that people are suffering from a brain disease, then, or a brain disorder, then we are able to help these people walk a sober life. And also to grow, strengthen, and unify the global recovery community, so that recovery is not only a possibility, but a probability for all persons who suffer from substance use disorders. On the next slide, we'll look at the recovery capital. Recovery capital is actually what can help you maintain your sobriety around you. What is there around you that can help you maintain your sobriety? Because this is it's about maintaining the recovery. Recovery capital includes strengths and resources that bring people to the recovery process. What can, for example, if you're still active, what is it that can help you, get onto the recovery path? Is it joining an AA meeting? Is it joining a support group? Is it joining a drug-free network? Is it maybe attending church and being embraced by the people who understand you? Or is it family? And then it is made up of all the assets, both material and non-material, that can help an individual start and stay in recovery. But like I said earlier on, being sober is easy. Maintaining sobriety is what is a bit difficult. But with the help of the people around you, with the right resources, with understanding from other people, accepting that this is who you are and this is who you were then you have plans, you have goals that you have set, and you are accomplishing these goals one by one, not rushing to do everything at the same time, will also help you to maintain your recovery. It is also building recovery capital is a dynamic process. It takes practice and usually includes mentoring and forms of support from others. Those who've been in recovery before us, or we who've been in recovery before others, should support the newcomers who are into the program. And then recovery capital can be internal, such as persons' individual qualities, or can be external, such as personal, financial resources, practical skills, ability to learn from one's own mistakes. It is very important to learn from your past. What is it that I did that did not go well with me, did not go well with the family? And this is the time to actually own all your mistakes, own all the bad things that you did to family, and make amends, first of all, with yourself as a person, then make amends with the significant others who are around you, because you need them, you'll be with them every day. And guilt and shame is actually what drives most of us back to drinking, to drugging, because we never made amends. We never said sorry to the people we harmed. So every time we see that person, we want to hide, we want to run away. So it's always good. And actually, the program, especially the AA programs, talks about making amends with the people we harmed. So on the next slide, we are going to look at the individual recovery capital. The individual recovery capital, social, and then community. The next slide, we see what we have in the individual recovery capital. In the next slide, Willingness to change. That's the first step. Willingness to change, to become a better person. And actually, at times, people do not know where to start. People who are abusing substances do not know where to start, because most of us we look for the bad things, the ill about that person, and forget about the good in that person. So for example, the person who took me to rehab actually reached out to me when I was drinking. He found me where I was drinking illicit brews, and actually brought out the good in me. He used positive psychology to bring out the good in me when everybody else was bringing out the bad. So let us look at the good in this person, the strengths that this person has, the good side of this person, bring it out so that actually they have hope. Because the most important thing is hope. Once this person has hope that there is life after what they are going through, after the pain of substance abuse, after the pain of being rejected by the society, by the family, by friends, there is hope of becoming a better person. Then the willingness will set in, and this person will look forward to changing. And supportive, conducive environment, e.g. a home. Do you have a home? And do you have a stable source of income? These are some of the individual recovery capital that we should build. And also a supportive family. A supportive family by making amends to the people we harmed, by also the family attending family sessions while you're undergoing treatment, be it residential treatment or be it outpatient treatment, or be it community-based. And then emotional stability, learn how to deal with anger and stress. How do you manage your anger? How do you manage your stress? Because in active addiction, anytime you get stressed up, you run to your drug of choice. Every time that you get angry, you calm down by using the drug of choice. So look for other ways of managing your anger, your stress. Look at the stressors, deal with the stressors, and you'll be good to go. Also, we have stress management sessions, maybe with a primary counselor, or you can share this in the support group. And then maybe somebody in the support group can work with you. And always take a step back, a step or 2 or 10 away from the stressful situation. Walk backwards from the stressful situation, and then call another person in recovery. You can call another person in your drug-free network. You can call a person in AA. You can call your primary counselor. You can call your pastor or a person who understands you and say, this is what I'm going through. If it's someone who has angered you, always walk away from that person and then talk about it immediately so that you calm down. Otherwise, anger and stress can actually trigger someone to go back into using substances very easily. Psychological stability, always remain calm. Try to remain calm as much as possible. Dwell more on positive thoughts. I had instances when people would always take me back to where I'm coming from. You know, when you used to drink, you used to do this and this. When you used to drink, you used to do this and this. So I learned how not to respond to their judgmental talks, to their judgmental way of conversation. So I learned to tell myself, whatever they are saying, I'm past that and I'm moving forward. This is me. That is the me they knew. This is the me I know. And then, self-esteem, self-worth, once it sets in, whatever someone says ill about your past life will not bother you. So personally, I've learned how to have all positive thoughts, turning lemon into lemonade. They talk ill, I always think opposite of what they've talked ill. And that was what has kept me sober up till this time. And then physical health through treatment. Always, whenever you feel unwell, don't self-medicate with prescription medication, over-the-counter drugs. It's important to have a balanced diet, because in active use, most of us were so malnourished because we either did not eat, or even if we ate very little. And then also exercises, they help a lot, especially if you're feeling low, if you're feeling like you're feeling down, you're feeling like, don't want to talk to anybody, go to your room and do some exercises. You don't have to go to a gym. Just like I said, let us use what is available. Things don't have to be very, very expensive for you to maintain your sobriety. You can even make your own lifts, and you'll be lifting. Get a rope and skip in the bedroom or outside. And at times I go out and play with my grandchildren also. So we chase each other and run around the compound, and this is good therapy for me. And so self-esteem, self-worth, and self-awareness, and that's what I said. You know yourself. Know what your strengths and your weaknesses, and nurture your strengths more than dwelling on the weaknesses. So self-awareness, self-worth, high self-esteem, that's very important. Self-care by attending support groups. So support groups at times cannot be near where you are, but with these days we even have online meetings. So it's always good. And if there's no support group and we have few people within that town, within that estate, you can always start a support group. Once you are 2-3 people, you can always start a support group. And then talking about taking responsibility of one's recovery by making amends with the significant others. That's very important, because the people around you, let them not live with you remembering about the dark cranny of your past, but they should see a new you, a new person in you. On the next slide, we are going to look at the social capital. Social capital, we can have gender-specific drug-free networks, e.g., friends who are longer in recovery as role models. In here in Kenya, last month we opened a women-only treatment facility, and which is something I've always looked forward to for the last 18 years. And so there's somebody who's opened that treatment facility, and it is awesome, because at times when we mix the male and female, some of our people have been actually even sexually abused or emotionally abused, or have been in toxic marriages and toxic relationships. And then when you get into a treatment center, you see a person who looks like your husband, or looks like one of the people who raped you. So gender-specific programs are very good, and also gender-specific networks, although at times we should also mix. We should not isolate ourselves, even if we have gender-specific treatment programs. After that, as we heal, we should start now reaching out to each other, walking around with each other, not necessarily isolating ourselves as women or as men in recovery. So support groups such as Alcoholics Anonymous support group, Narcotics Anonymous support group, Al-Anon for family members who have people who are abusing drugs. And then we also have Al-Teen. This one is for teenagers who are living with parents who are using substances, or teenagers who are also using substances. The Al-Teen meetings are usually organized by the Al-Anon support group during school holidays, so that they can be able to attend when they are not in school. We also have another support group called ACOA. ACOA is Adult Children of Alcoholics. My firstborn daughter, who lives in the US, she has joined ACOA. She needed that support a lot because she never had time to be a child. I was an absent parent, and so she started parenting her siblings when she was still a child. So this has been a good support system for her. So I actually recommended that support group for her, because she was so used to controlling the siblings that even when she grew up, she could not stay in a relationship. She wants to control the person in her life, and she was even trying to control me. Mom, I don't know what you're going to wear. Mom, I don't know what meetings you have today. So they become controllers. They might not be using, but then they need to live their own life. They don't know how to live their own life. They know how to control other people's life and forget about themselves. And usually they will eventually lead a very, very miserable life. So gender-specific treatment facilities, like I'd said, making amends to significant others, family members, and also religious organizations, churches, mosques, temples, etc. This is, again, what I said earlier, collective responsibility. Religious organizations, let's embrace these people who are using substances. They are human beings. Let's learn how to separate substance use disorder from the person. The person is actually suffering. But we join the two, and we start now isolating, neglecting that person. We see them as evil. But you hear a parent say that when this person has not drunk, he's a very good person. So what is making this person bad? This person is still good, but what is bringing the negative energy in the family setting or at the workplace? It is the drug that this person is taking. So separate the person from the drug, from the drug, and actually close in on the behavior brought about by the drug of choice, because it's the behavior. When they shout, when they scream, when they steal things, the behavior brought about by the drug of choice. Otherwise, when you keep on telling this person, you are so evil, you are so bad. I was chased away from church. One time I wanted to get born again, and I went to church. I wanted the pastor to pray for me so I would stop drinking. I was thrown out of church. And that's the first time I attempted suicide. I went and took prescription medication and overdosed. I was rushed to hospital, and I was very annoyed with God the following day because I was still alive. I just wanted to die because I'd fallen out with everybody, including my own friends and my own children. So social capital can also be a job or even financial capital. Maybe you have a small business, or maybe you have a job. After treatment these days, for Kenya, we have a policy, alcohol and drug abuse workplace policy, whereby people are not sacked. They're given time, sick leave to go to treatment, and then reinstated, come back to work and continue with your working. And most of the times, depending on the company, depending on the government department, it's the company that pays for you the first time that you enter treatment, and then the second time maybe you pay for yourself, depending on what kind of policy they have. But these days, people with substance use disorders are not being, their services are not being terminated. And then availability of healthcare institutions. This is very important, so that identify a hospital, identify if you have a medical scheme or something like that. Here in Kenya, we have one, a government one, which is not very expensive. So it's always good to pay so that whenever you get sick, you can go to hospital, and then it doesn't take a toll on you. So on the next slide, we're going to look at the community recovery capital. So enforcement of laws and policies that govern availability, affordability, and accessibility of the substances.
Sorry to disturb. I'm just going to warn you about time, so if maybe could start bringing it together.
Okay, I think this is about the second last slide.
No problem. Thank you so much.
Yeah, this is so like I said, the policies that we have at the workplace, and then the laws. Like here we have bars opening. Bars should open after 5 o'clock in the morning. In the evening. No bars should open during the day. So we minimize availability and accessibility. Affordability, now we are going to put more taxes on the alcoholic beverages, and then limit of alcoholic drinks outlets, especially the wines and spirits where they sell alcohol anyhowly. And they're just small shops at the corner where you can go and drink and leave. And then cultural values and norms that support recovery. I think I talked about that very well. And then training community on the effects to enable them accept the affected persons. So when it comes to reintegration into the community, if the community is well trained on the effects of these substances and the need to embrace these people when they come back from the treatment facilities, embrace their recovery, support them where need be, then that is very good. It becomes very supportive. Community involvement in demand reduction and supply suppression. On the next slide, kindly. We all welcome you to join the Global Recovery Network. We promote research-based recovery messaging, connect with recovery allies and peers, learn about upcoming events, and join our monthly dialogue. So you can actually scan our code, and then you can actually join and be part of GRN, you're most welcome. Thank you.
Thank you so much. And I was trying to find the buttons to put myself back on screen. Technology. Thank you so much. And so we'll deal with the questions and answers at the end of the session. I'd like to invite Samba to go ahead and take us through ISSUP Botswana. Please go ahead, Samba.
Thank you. Well done, Anne. That was great, brilliant. Very, very little to add to that. Thank you very much for this opportunity to be here. As introduced, I'm Dr. Samba Nyirenda, based in Francistown, Botswana, and a member of the Botswana Addiction professionals. Okay, so I am just going to share lived experiences of women that I've been able to talk to with regard to their experience living in Botswana or in Africa as women who were experiencing a substance use disorder. And I'd like to start with just talking about myself, basically, as a woman in recovery, as I see myself. That for me, one of the greatest gifts of recovery has been being to own my own feelings, attitude, and behavior. I did not know how to be with the feelings that I was experiencing. I did not know what they were called, that whether it was fear, anxiety, loneliness, tiredness. I just knew it was a very uncomfortable, yucky feeling that if I took a drink, it went away. So for me, one of the greatest gifts of being in recovery is just being able to be with my feelings, sitting with pain and with uncertainty, and just realizing that I'm not my thoughts or my feelings. Because I used to think that whatever I was thinking, whatever I was feeling, that's who I was. I identified myself with that. And today I know I'm not. So that gives me that kind of freedom and space. Because my drinking, I came to learn, and was driven by the fact that I experienced a lot of anxiety, fears that I did not know how to manage and to cope and to deal with. Other people also get to experience those same things, but they seem to have ways of knowing how to navigate life, which I did not seem to know how to. And that is so that once I stopped drinking, I had to learn how do I now live with life as it's unfolding without picking up a drink. And this has been one of the greatest gifts that I've received in recovery, is that I'm just able to be with whatever is unfolding and just acknowledging what is there. I don't need to act on it. I don't need to push it away. I don't need to cling to it. And this has come, it has come to me gradually in some of the 24 hours that I've been in recovery, in when I started exploring more the gift of mindfulness and present moment awareness, and the meditative practices, and how to quieten this busy mind of mine. And it has been further consolidated by lifestyle medicine finding me and being able to incorporate the pillars of lifestyle medicine into my life and into my recovery. And I'll talk a little bit more about that towards the end. So having said a little about my own experience and how I'm grateful I can now own my own feelings, attitude, and behavior, because this was some of the things that I struggled with and that drinking helped me to escape momentarily. I just want to talk a little bit about the experience of the other women that I've had the privilege of communicating with and what they have shared about their journeys with regard to recovery. So some of the things that come up is that there was a lot of struggle, internal conflict. One says I was ashamed because I was drinking and a smoking woman, and this shame led me to being defensive, acting aloof. borderline aggressive, so I would often be in direct conflict with men who tried to approach me. Women rejected me because of this attitude. I suffered a lot from guilt because of the time I spent away from my children, spending money I should be using for them, and then coming home too drunk to spend any quality time with them. Loneliness came from my aloofness because I wanted to be seen as decent while doing indecent things like drinking in the wee hours of the morning and smoking. Wanting to be seen as one of the guys led to my isolation because intrinsically I'm a feminine woman, but I didn't want to be seen or associated with the typical bar hounding woman. In my last days, I drank alone, though I craved companionship. So there's that loneliness. I fear because as a woman, I was always in danger of being drugged, raped, or assaulted. Fear judgment from society. Failing to balance my time, finances, and family responsibilities. Harmful emotional attachments to stave off the loneliness. Aside from having to accept that I'm an addict, it was having to recover alongside men in the early days, obviously not knowing much about the program and having to be present no matter what, despite feelings of intimidation, being amongst men and vulnerable. Then others said I received a lot of stigmatization because our African culture, drinking and smoking is socially unacceptable. I think Anne has spoken beautifully about these experiences. More so if you become a social outcast due to the mismanagement of one's lifestyle. Another talks about becoming a sex target due to the vulnerability that comes with blackouts and due to low self-worth, self-esteem, a warped sense of love, endless cycles of toxic intimate relationships. And another said, on my first attempt to stop, I realized that local authorities and societies had not yet built awareness of the outbreak of untreated addictions, so I struggled to seek immediate help in arresting my addiction. Treatment options were limited at the time, and I think they still are even now, as well as the understanding of the knowledge of addiction. And I think Anne spoke beautifully to this, that, you know, there is just that knowledge is not there, and it is not seen that this is, it is actually a disease, a disorder, and it is not just a moral failing. Yeah, and that it has it causes symptoms and it has its treatments that can be known to be effective. And this one says that they do not blame anyone, but they say this is just what the experience was. Another thing I thought would be interesting to know would be, did you know what was wrong with you? Because I certainly had no idea what was wrong with me. I just thought I was, you know, a useless, hopeless, unreliable woman. I just had no idea. I had no idea at all. I did not know that I was a sick person, not a bad person. In the early days of my drinking career, I did not know what was wrong with me. I thought maybe I was suffering some kind of depression, somebody says. Somebody else says, I had an idea of what could be wrong with me. I knew I didn't drink and drug the way other women did. And there was too much shame to come out and seek the right help, because mostly men have such kind of problems with substances. And it makes me less of a woman amongst society, family, and friends if I admit that I've got this problem. Another woman said, yes, I've been around long enough to know I am an alcoholic, but I had a lot of reservations. There were many failed experiments, trying to drink and not to get drunk, I guess. Yeah. I asked the ladies what were some of the hardest things that they experienced or that they can remember. And this one said, having to face my child in the morning, knowing I might have gotten off drunk last night and the fumes from my drinking last night before. Another said, failing to be a present mom even though I was at home most of the time. So I'm at home, but because I'm in a haze of alcohol or drugs, I'm not really present for my family. Knowing that drinking was bad for me and not being able to stop it. And another one says, the hardest thing for me has always been putting down the drink, but by the grace of God, eventually I chose to embrace this new life. And then I asked these awesome ladies, what is the greatest success you can celebrate? And some of the successes that they said, actually getting clean, working the program, honestly, open-minded and willing, recovering, and understanding and being comfortable to be around men and understanding they too are here for the same reason I am, that we all have the same problem. Others have talked about developing business achievements, and others have talked about developing the confidence to speak their truth without fear or rejection or judgment. Another said, for the first time in many years, I'm able to sleep sober and wake up sober. To be living sober, useful member of my community is a great success that I have the privilege to celebrate. And I can echo to that, to wake up sober is a great gift with a clear head. Yeah. And then we ask them, what would you like to see available for other women with substance use issues? And it's just, I think Anne has covered those so beautifully in her PowerPoint presentation, all those wonderful bullets. And I think it's just the same, that more support from the society, including employers. Others have talked a mobile app and services for when they need help, and the places of safety and rehabilitation where the mother can go with her children, centers that can focus on women only. The formation of recovery-related women's meetings outside the general fellowship, because there are sensitive issues that women experience that as women, we can't openly blunt out in mixed meetings. It would be nice to have such spaces for such shares. So women-only meetings, gatherings, fellowship, so women can feel free when starting their recovery journeys, where they can also be safe from possible, what Anne was alluding to, being sexual predation or other such negative consequences that can happen in early recovery as people are still trying to find their feet. Rallies, mini conventions, etc. So I would also like to add to the beautiful recovery capital that Anne talked about, that I found that it's really important to also speak to other aspects. Too often we focus on just getting somebody clean or sober, and that's it. And okay, clean is sober, and okay, we're teaching them the tools, etc. But we're not inviting them to look at other aspects of their life. We need to clarify that as a lifestyle medicine specialist, I have come to see the importance of our nutrition, our exercise, sleep, all these as very important factors if we are to recover as whole human beings. Too often they can be, especially once in recovery, that we can go from one addiction to another, what we may call cross addictions. I experienced that myself because where even as I was working my recovery, I was not drinking, I was not smoking or whatever, but over time I developed this very unhealthy relationship with certain food substances that drove me into what was actually an addictive kind of way of eating, and with consequent health problems and health issues. And in my mind, I thought, because I'm not drinking, I was okay, so I could deal with this. And when I needed to deal with it, no. And then sitting down and coming to another program, I came to understand that actually what was happening is I had gone through some stresses, etc., and now I was medicating my emotions with my food, with the food choices that I was making. So again, it was to slow down and to start knowing how to be with my feelings and with whatever it is that I was experiencing. But I'm pointing this out because many times when people go into rehabs and all that, we're fed a lot of sugar, sweets, and whatever, all these things, that just as long as we're not drinking, we're not smoking. And I think that can be the opportune time to be able to bring in these other lifestyle interventions. There have been studies that have shown that when we offer a predominantly whole plant-based nutrition full of fiber, with less processed things and all that, our mental health is better. We do better. And they've actually done these studies where the people in rehab, they've offered them these different diets, and those who are offered more wholesome diets could do better in terms of their cravings, etc. So there's something to think about. So this is, in lifestyle medicine, we have this acronym from the Nigerian Society of Lifestyle Medicine called DREAMS, DREAMS. And allow me to just share these dreams with you, because I think they're so important as part of consolidating recovery, and we need to talk more to them apart from these other things that we've been looking at up to now. So apart from the diet, which is predominantly whole plant-based, full of fiber, fruit, vegetables, etc., less processed things, less chemicals, less added fats, etc., that is evidence-based that it will help our mental health and our overall health. And then we've got relationships that I also spoke to so clearly. So, and by the way, the dreams is just the traditional African diet that people were eating in the villages. Yeah, not only protects against those chronic conditions like the diabetes, cancers, etc., but will also help the mood and your resilience. Okay, then we've got the relationships. So positive social relationships. We're living in society. This is so important. And then I talked beautifully about that. So the Ubuntu, the village, positive social relationships. And I think where one has got a face-to-face meeting, go for a face-to-face meeting. Don't just go on Zoom because you can't be bothered to, walk across town or drive across town. If you have a face-to-face meeting, try and get to that face-to-face meeting and be with like people and, in the same room. And it makes a big difference because there's hormones and all that come up and help us to have this really feel-good feeling inside that lasts for a long time. And then there's exercise, movement, especially when we are also experiencing a lot of depression and anxiety. So regular exercise, even if it's just walking, jogging, whatever, and especially if we can do it in groups, that's a great recovery capital to work on too. And then, of course, avoidance of risky substances. Sorry?
I feel terrible interrupting you.
Yeah.
So I feel terrible interrupting you. I just want to make sure that we have a little bit of time as well for Nimesh. So
okay.
Thank you so much.
All right. So avoidance of risky substance use, we've talked about that. Mental health stress reduction, which is what we're talking about. For me, mindfulness helps me so much. And of course, restorative sleep, not skimping on our sleep. We need to sleep so that our bodies are rested. And that is how we can consolidate our recovery capital with dreams. Thank you so much.
Thank you so much, Samba, just for your genuine sharing and for you and Anne as well. I think it's just such an important perspective to understand the experience and the strength required and the challenges of trying to find yourself and recognize how you can still appraise yourself positively in spite of all these challenging experiences. So thank you for sharing that. Nimesh, if I can ask you to start.
Yes, of course.
What I'll ask my panelist colleagues, if you can keep your eye on the chat pane, what I'll do is I'll paste some of the questions that are coming from our audience in the chat pane, so that you can have a look at them. So you can maybe start answering some of those questions by replying, and then you can select that you reply to the audience, just to make sure that we're able to start getting some of those questions to the make sure that they're able to engage some of those questions. So while Nimesh speaks, please do start trying to answer some of those questions. So remember, when you reply, to paste your reply to the whole group and not to the organizers and panelists. Nimesh?
Sure. Thank you. Thanks so much. I'm very briefly to recap. I'm so thrilled to be with this ISSUP activity as the initiation of my contact with ISSUP. And let me just make sure I can start sharing the screen. I want to very sincerely, briefly applaud and appreciate and commend what these two lady colleagues have highlighted, both Anne and Dr. Samba. Am I able to get to the screen? My request, friends, is going to be this. I'm going to try and not read everything that's on these slides. I will request all of you. Okay.
Nimesh,
I request all of you.
Screen.
Sorry.
We don't see your slide deck just yet.
Yes. Yeah. Can you now?
Sure. All right. Not
okay.
Yet?
Great. Right. Not yet. Okay. All right. Can you?
There's it. Now we see it. Thank you so much.
Okay, thank you. So my request, friends, is going to be, I'm not going to read everything that's on the slide. So I will request all of you to be alert in terms of visual and audio input both. I'm just going to say things that supplement the material that's on the slide. And if ISSUP would permit, we'll all be happy to share all the slides with whoever would like. So there's a lot of material that's on the slide that you might all want to look up later too. I want to begin by thanking these two from India and one international consultant who is with us in India for quite some years, for all the input that I've had, besides a whole lot of people in recovery that I've learned from in last 3 or 4 decades. That's briefly how I see transitional societies in Afro-Asia. Let me quickly go over the types of PRPs or persons in recovery as I see PIRs. There's a group of peer volunteers who apprentice, who intern. That's a more informal, semi-formal arrangement that at least in India that we have, and I think many countries have. What in India has been very good about through efforts of my colleague and friend Dr. Rajesh Kumar and others is that there is actually an officially recognized position of peer educators with modest salary from the government or the other agencies for almost 2 decades now. Then there is a group of peer counselors who are not really very well recognized officially, except for the AIDS program that recognizes the role of peer counselors. And of course, there are some people who have become peer counselors and managers of teams and field work. And there are some very worthy examples, including Subhimal, who helped me with this. And then there are quite a few examples, unfortunately, double-edged sword, of program managers, persons in recovery who have kind of got into setting up rehab or treatment centers, quite often for commercial reasons, for money making, and not necessarily always well regulated. Dr. Rajesh and I have often been in judicial and administrative review teams, which are now coming up to see that this unorganized sector becomes a little more organized and regulated. And that's the current scenario. There are 478 drug treatment centers. Each of them have one peer educator, salaried position, and 3 to 5 peer volunteers, which is of course an apprentice job. And then there are of course 283 or so targeted intervention programs, including HIV/AIDS, where there are peer counselors, with some very few worthy examples of peer counselor managers, as I and my colleagues see them. The thing that I want to highlight here with all of you friends is that from my exposure and learning in health and mental health beyond substance abuse treatment, I realized that while substance abuse treatment, especially alcoholism, has been one of the first few to recognize and accept persons in recovery as treatment professionals or part of the team, there are quite a few good examples of how lived-in experience is actually important. So this is a movement that's cutting across mental health and health field, let's be sure. And of course, not to be confused with the A&M movement, which is great. There are also a whole lot of user carer movement in mental health and a whole lot of health fields where the role is limited to advocacy or awareness or providing peer support, but not really becoming part of the treatment team as we seem to in SUD follow. I have tried looking at in last few weeks, especially after we crystallized the topic, how and why is it that some health conditions seem to be more important for lived-in experience being relevant? Mental health, leprosy, whole HIV, a whole lot of others. One, health conditions where there are myths and social stigmas leading to exclusion and ostracization. And so there is a need for those who have recovered to kind of get into the role of helping the individuals and society. And of course, one must admit as professional that there are limitations and inexactitudes of treatment in quite a few fields, including substance abuse. And like it's been referred to by these two ladies very well, there are needs of concept of recovery beyond symptom amelioration, being just abstinent or drug using or treatment goals as medical science would see it. Also cannot not mention that the relevant aspects of SUD professionals' work and attitude is also contributed to this welcome step of persons in recovery joining treatment teams. Medicine, psychiatry included, medical science, it seems, objectivity is the touchstone. While that is good, that need not be the only hallmark I do want to say to this group and put on the table. And then, of course, professionals have mental health professionals or healthcare providers who work in substance abuse treatment also have their own socially influenced attitudes from childhood experiences. I know a number of health or mental health care professionals who are in substance abuse treatment or in such areas who actually went through childhood experience of alcoholism and domestic violence. And then they carry that for good and not so good effect. And then, of course, there is ambivalence that many of them carry about how useful or effective the work that we all do is. And of course, there is this possibility of burnout that I see distinctly more in some areas like substance abuse treatment. Let me briefly share what I have learned over the last 4 decades or more in India, but internationally too. There was a time 40 odd years ago or 35 years ago where a person in recovery automatically became a part of the team if he or she was interested. All that mattered was passion and the willingness and the keenness to help. What happened, I believe, in the 1990s and around there, around the turn of the century, is that there began to be a need for recognizing professional perspectives in addition to someone being a person in recovery. And so around 2000 and after that, I see a huge welcome step in many parts of the world where persons in recovery or peer service providers are encouraged to go through capacity building or formal certification exercises where you then get a good merging of both the matters of the heart, the passion-driven desire to help, and some amount of professionalism and professional knowledge. By now, I think 2020s, there is also beginning to be a lot of recognition. I won't bring that to everyone's notice. Mental health care providers, mental health professionals with substance use experience, who are now more forthcoming than they were earlier, to say, okay, I have been through an alcoholism or a substance use experience. I have recovered. I'm a mental health care professional. I'm going to combine both those experiences in trying to help everyone else. But in line with that, I just want to briefly share this too, if you'll all notice, including psychiatrists, clinical psychologists, mental health professionals, which I think is a huge welcome step. Lastly, allow me to share very quickly on the next 4 slides my understanding and my colleagues, our team's understanding of SWOT analysis of this phenomenon of active involvement of PSPs or PIRs in SUD treatment teams. What are these trends? Better acceptance by patients and clients, higher level of compassion, ease of rapport formation and trust, easier identity for the person concerned, client, to follow as a role model. And of course, there's a whole lot of programmatic cost saving that we cannot overlook. There are obviously a few weaknesses. Possible lack of objectivity, sympathy taking over empathy, possibility of boundary violations, missing out on medical or mental health important issues in the client, and perhaps sometimes the lack of clarity or conviction about the goal of treatment in a given person or in a program. Abstinence vis-a-vis harm reduction. The opportunities, of course, are also quite a few. The biggest opportunity I see is for substance use treatment to demonstrate to the rest of the health and mental health care field how there can be meaningful complementarity of technical expertise and lived-in experience or expertise. The enrichment of learning that happens for both the groups. Participatory treatment process being much better for recovery, as these 2 lady colleagues wonderfully enunciated, over limited goal of treatment or abstinence. And then, of course, by involving persons in recovery in treatment teams, I believe we get one step closer to communitization of SUD services. Obviously, there are a few threads which I would prefer to see as challenges. There are sometimes in the team territoriality issues. There are issues of whether contradictory messages go to the patients or clients from different parts of the team. There have also been issues where there have been serious arguments within the team between professionals, healthcare professionals, and PRPs. What happens when a person in recovery who's a good peer counselor or peer counselor manager relapses, as is inevitable sometimes? And so that's another issue that we really need to be aware of and be prepared for, possibly have a standard operating procedure as to how we deal with it. I also do believe, with all respect, that sometimes there is this toxic positivity or the high of having been abstinent and been in recovery for a fair length of period, that can make the PRPs or PIRs overconfident. In a lighter vein, if you might see this, while it's great to follow the pressure cooker example, sometimes it can misfire. I want to put it to you. And lastly, as was already referred to by Dr. Samba, both in fact, ladies, self-awareness. All of us can benefit from that. Certainly our colleagues who are in recovery and who join as treatment team colleagues might benefit a lot more specifically from self-awareness. One example being Johari window that I wish we would have more time for discussing. Lastly, in this field and the overall topic that we are talking about, all three of us today, what are the possible future needs and directions? One, there needs to be even better synchrony between the two streams, professional and lived-in expertise. We need to really encourage more and more PIRs as parts of teams and also help healthcare providers or mental health professionals who are in SUD recovery to own it up, come forth and join. Document more case study experiences, which I really think is still lacking hugely across the globe. Generate more research evidence, specifically in the context of how PRBs or PIRs actually have better acceptance and perception by the clients. Document experiences and research about team coordination. Document, if we can, the qualitative, also possibly combined with some data sets, cost-benefit issues of the phenomenon that we are talking about today. And with that, friends, I'm coming to an end. I hope I haven't taken too much time. And that's the email any one of you would like to communicate through. Thank you so much, Dr. Sebeko, ISSUP, everyone involved. And I'm going to
thank you so much, Nimesh.
So, thank you.
Very much appreciated. I think if our colleagues can also bring their cameras back online. So in the period while you were talking, Nimesh, the world has fallen apart on my side and reconnected itself. I had a power outage, I lost connection, but I still managed to follow you. So congratulations on a great talk. Some of the reflections you share about peer involvement really mimic some of the conversation around task shifting and task sharing, isn't it? There's questions around territory, there's questions around supervision and quality and confidence and overconfidence. So these are all areas that must really be taken into account when it comes to looking at ways to incorporate peers in recovery provision, support provision. And I think I just want to thank again Anne and Samba for the very important reflections on the recovery journey and highlighting how important it is to consider recovery capital very carefully and being able to analyze each individual's recovery capital, because it's not going to be the same for each individual, and understanding that one set of interventions may not be appropriate for another individual. I think the real core takeaway for me there was that it's about community, and it's about a sense of belonging, and it's about a sense of accountability, taking accountability. It's about dealing with feelings of guilt, feelings of shame, internalized stigma, dealing with issues of social exclusion and social accountability, loneliness. You spoke about the aloofness, Samba. So these are all themes that are just so important. So colleagues online, we have been deliberating in the background what to do about where we are in terms of time. There is no way that we can get, your questions were just so rich and so important. So we're going to strategize on a way to get together and respond to all of your questions, because I don't think we want to rush them. We want to make sure we do them justice. So please accept our apologies for that, but we will convene and make sure that we come back to you with responses to your questions. So that having been said, I want to thank our colleagues from the Global Recovery Network and ISSUP Botswana for such heartfelt sharing, such sincere delivery, and it was really meaningful and helpful. So really appreciate that. And to Nimesh for sharing some of the considerations around involving people in recovery. So this will conclude the webinar for today. Please expect some communication from us in future. We will hope to address some of the questions that you've shared. Thanks for attending. We really hope you found it meaningful. From the reflections that I've had from the chat, I can see that a lot of people found it valuable. We always appreciate your feedback and suggestions, so please do use the link in the follow-up email to complete the feedback survey. That's going to come, it's going to reach you in the next 24 to 48 hours after this webinar, and you'll also be able to view a recording of this session. So on behalf of ISSUP, I want to just really thank you for spending this hour with us, and thank you to our colleagues again for sharing. And I want to wish you all a fantastic rest of your day, morning, evening, and we'll catch you again in the next webinar. Take care.
Thank you.